Hello, and welcome to the Chicago Humanities Festival and today's program, Beth Macy and Dopesick. My name is Monica Davey, and I'm the Chicago Bureau Chief for the New York Times, where I work as an editor on the national desk and as a correspondent covering 11 states in the Midwest. This year, thank you. This year, CHF is celebrating its 30th anniversary of provoking smart conversations around the city. Thank you for joining us today as we explore our 2019 theme, Power. Learn more about other upcoming programs and take a look back at our incredible 30-year history by visiting us online at chicagohumanities.org. After this program, please join us for a book signing at the south side of the lobby. Beth Macy is a New York Times bestselling author whose latest book, Dopesick, Dealers, Doctors, and the Drug Company That Addicted America, was shortlisted for the Carnegie Medal and won the LA Times Book Prize for Science and Technology. Please help me in welcoming Beth Macy.
Thank you for coming.
So in your book, you trace the rise of opioids as they stealthily made their way across southwestern Virginia from the points of view of young people, of parents, law enforcement, dealers, doctors. How did the crisis get so far before it was even recognized?
That's a great question. I argue in the book that, this crisis begins in the mid to late 90s, basically around the introduction of OxyContin and the pushing of this incorrect message that opioids were now safe, when for 100 years we knew that they weren't safe and should only be used in cases of severe pain, end of life, and cancer. And what Purdue and other makers did was they flipped that narrative to incorrectly say that these are now safe for all manner of pain, including moderate pain, TMJ, back pain, who doesn't have back pain? And it starts out as a problem in these distressed rural factory towns, such as the ones in central Appalachia, rural Maine, fishing communities, places like that, because those pharma reps actually targeted those areas. Because they were already places where there were large amounts of workplace injuries. And so doctors, they were already comfortable prescribing opioids. But OxyContin, in comparison, was really heroin in a pill. It was like a nuclear bomb. There was more pure oxycodone in it than anything had come before. And so that happens at about the same time, not long after NAFTA comes and takes the furniture and the textile jobs away. China joins the WTO in 2001. All these things are happening at the same time in these small communities. And oh, by the way, papers like Monica and I used to work together at the Roanoke Times many years ago are no longer covering those areas. So the media abandons these distressed rural communities. At the same time, they needed us. They absolutely needed us more than they ever needed us. So I argue that the epidemic is allowed to sort of fester and grow because we just weren't paying attention to those communities, by and large. And then when it does come to the cities and the wealthy suburbs, such as Hidden Valley, which is the photo on the cover of the book, it continues to get ingrained because people in the wealthy areas had the money to hide their addictions. The kids that started out taking pills from their parents' medicine cabinets and got hooked could tell their mom their laptop or their iPad was stolen, not that they had pawned it for money to buy drugs. And the few parents who were in on the dirty little secret could afford to send their kids away to rehabs, but they were not going to tell their neighbors about it because of the stigma and the shame surrounding it. When I first started writing about this issue in 2012 for my newspaper, hardly anyone wanted to go on the record about it, even though so many people were already dealing with it in their families. But now, as it becomes more and more entrenched, by the time I was finishing up the book, most people were okay with it because almost everyone here knows somebody and has suffered from this or knows somebody that's suffered from this. And so it was kind of this double whammy of economics and shame.
So what made you decide that this was a book you should tackle?
Well, I had first written about heroin when it hit the wealthy suburbs. And normally for my newspaper, I covered, this was 2012, I wrote about marginalized communities, inner city, refugees, immigrants, caregivers for the elderly. Like, these were the stories that were kind of my beat. But the story on everybody's mind then was the fact that these two families, upper middle class families, had gotten ensnared in it. And readers sort of literally spit their coffee out and said, "What? Wealthy white kids are doing heroin? We had no idea." I went on shortly after that to write my first book, Factory Man, which was about the aftermath of globalization in these distressed communities. And even I was seeing a lot of drug-related crime in those communities, but not really putting it together with the OxyContin story that had happened earlier. I actually suggested to my then agent and my then editor, after I finished Factory Man in 2013, that maybe I should look into heroin as a subject for a next book. And they both said, "Heroin? You know, these are people who live in New York, AKA not the real world." And my agent actually said, "Oh, we think you're just late getting it there." And I sort of, almost like it was a trend, right? Because he hadn't heard of it. Because again, people are keeping it quiet at that point. And it wasn't until 2015 that Deaton and Case, the Nobel-winning economists, dropped this bombshell study showing that for the first time in American history, our life expectancy is going down. And it's going down largely due to drug overdose deaths, suicide, which is also just off the hook, and things like cirrhosis of the liver, mainly among middle-aged men who hadn't gone to college, but among all demographic groups. And so we were just talking earlier, like, it took the economists to tell us we're in the middle, and we have been in the middle of the worst drug epidemic to hit the nation. But by that point, by the time you started seeing national stories about it, the genie was already out of the bottle. You know, we now have 2.6 million Americans addicted.
So your description of being dope sick is so vivid that I almost felt physical pain reading your description of it. And your descriptions of what using heroin is like were also really painful. You quoted one recovering heroin user this way: "It was like shooting Jesus up in your arm. It's like this white explosion of light in your head. You're floating on a cloud. You don't know yet that the first time is the best. After that, you're just chasing that first high." So is the only escape from this never trying it at all? Is that the only escape from this?
It's not the only escape. I mean, we know now that there are life-saving medications like buprenorphine and methadone. The science is really clear that if you're somebody that has opioid use disorder, you're much more likely to live, because you can't get better if you're dead, and it protects you from relapse, criminal activity, and overdose death. So, but if we can wave a magic wand and just not have anybody start, of course, that would be great. But the important thing to remember is people don't have to die. Mm-hmm. You know, only 1 in 5 people with opioid use disorder has access to these life-saving medications, and that's what we need to be scaling up right now.
What's the reason that we aren't?
So there's a lot of stigma out there around MAT, medication-assisted treatment, the buprenorphine and methadone I was just talking about. And a lot of that comes out of sort of historical abstinence-only models from 12-step programs, AA and NA. And the research is just really clear that it's very, very hard to get off of these drugs without the benefit of those maintenance medications. And it's 65% versus 6 to 8% on an abstinence-only model.
When you say that, you're saying abstinence-only, you have a 6 to
8% recovery rate versus a 65% And it doesn't work for everybody the first time. And one person in my book says it's a numbers game. It might be the third or fourth time that you try. But the important thing is, and I saw it in story after story in the book, the people who had access to those life-saving medications, they weren't committing criminal acts. They weren't involved in drug gangs and prostitution. They were getting jobs back, their families back. And yet, I think only 2 of the people that I didn't quote by name in the book were people who were on MAT, and they just felt like they would be judged. I saw person after person be judged at NA meetings, and the leader told me not long ago, he said, yeah, there was a time period there where we were losing people 1 a week, because if they were coming to our meetings for support, but people found out they were taking Suboxone or buprenorphine, they considered them unclean. So they would allow them to come, but they wouldn't allow them to have a sponsor or really to actively participate. And I think that's starting to change now, thank goodness. But that really felt like daggers to some of the people that I followed on this trip, on this journey of trying to get help.
The personal stories of those who died from opioids and of the families that they left behind are really crushingly painful in your book. How did you go about pursuing those stories, and what were the challenges of that?
My good friend Roland Lazenby, who writes books, and knew I was really worried about getting depressed working on this book. And I don't want to sound like poor me. Like, I know the families that have dealt with this have gone through so much more pain. Just hard to fathom. And because I'm from a family with 4 generations of addiction, at least that I know about, there's probably more than that, I was worried that I would get depressed. And my friend Roland said, he quoted Mr. Rogers at me. He said, you do well when you write about the heroes. And Mr. Rogers said to find the helpers. So that's what I did. I focused on the families. I spent a lot of time with people who had either trying to be in recovery, or were in recovery, or were a few who were still actively using. But mostly I focused on the families and the first responders who were fighting back. And I picked these 3 geographic locations in Virginia, where I've been a reporter for 30 years, just hoping that would stand in as a microcosm for what was happening across America, occasionally dipping out and going to other places like Boston, which is much farther ahead in terms of harm reduction and treatment, just to show what the possibilities could be. But really, my ground, my little postage stamp that I write about is Virginia. So I picked these 3 areas, and then I picked different kinds of families and first responders that were fighting back in each of those 3. So I start out with, the first doctor in the nation who picks up the phone and tells Purdue that their drug is addictive. And he's got kids he immunized as babies now overdosing in the high school library. This is late 90s, and they didn't do anything about it. He was begging them to take it off the market, and so on and so forth. The big challenges were just trying to impose hope and order on a sad and chaotic story, right? Like, how do you storyboard that out? And I got it wrong the first time. I probably got it wrong the second, third time, but I had a really smart editor named Vanessa Mobley at Little Brown who helped me figure out an interesting way into the story that would have never occurred to me because it happened much later. She said, start with this moment where you're going to interview the drug dealer in prison and then go back. And then somebody else pointed out, well, that was exactly the structure used in Factory Man. So I don't know why you're having such a problem with it. But it just, you get these grooves in your head when you've read something a lot, and you don't want to mess with it. But she was absolutely right. And then she, because I started reporting it in these 3 geographic buckets. And then I just started peeling an onion in each one of those areas, right, to try to get deeper, to tell stories through these families and these people who are fighting back that wouldn't just leave you in a pile, but would actually have, some reason for hope at the end. But I have to be honest, when I finished the book in 2017, then right after the book is all edited and buttoned up, my main family that I had been following for 2.5 years, the young woman is murdered. So I had to go back and rewrite that. And I mean, how do you find hope in that?
Well, how do you? Tell us a little bit about Tess, who's the character that you're talking about, and what is the hope in her story?
Yeah, so there wasn't much hope in the story as I followed her, but there's been hope since then, and which I've continued to report on. I just did a podcast for Audible. It's an Audible original called Finding Tess. Her mother and I decided to go out and find out what happened to her. She had been sent out to Las Vegas to a rehab. It was an abstinence-only rehab, and she quickly sort of bombed out of there and then was homeless and prostituting on the streets of Las Vegas for several months. And so we set out to kind of try to retrace her final steps. And we did, and we found a lot of people who had tried to help her, and we learned a lot about the process. And one of the things we also did was we let her tell her own story in her own words, which I think was powerful. I had never done an audio project, and I didn't know I would be doing a podcast. I probably didn't know a podcast existed when I started working on this book, but I had recorded all my interviews just on my iPhone, and the quality wasn't bad. And so we were able to, you can hear Tess telling her story. And then as we set out to really examine this life, 6 years of addiction, we really went deep into where she had fallen through the cracks from that NA meeting. And then you learn so much more when you go back to people over a long period of time. You know, yeah. Robert Caro says time equals truth. And so I could take Tess to those meetings where no one would sponsor her, but then I go back to the meeting leader and I say, well, why did that happen? And what are you doing now? Right. And he realizes they were doing it wrong. And likewise, I could follow her after she overdosed and ended up in the ER of our local nonprofit hospital or in the ER for an abscess, a wound. And they would never, ever treat her opioid use disorder. Because they didn't have any physician's waiver to prescribe buprenorphine in their ER, and they didn't think it was their job. So in the podcast, you hear me interviewing the head of the ED in 2017, and he's giving me that old bit about it's just a drug replacing another drug, it's not our purview to do this. And then I call him back earlier this year, and he says, you know, we read your book, and we looked into the research, and we changed our mind. And now they have 24/7 coverage. The first month alone, they had, I think, 25 people into treatment. They beefed up their treatment capacity, and it was exactly what Tess had said that we need. The first time I interviewed her in December of 2015, she described how she'd been overprescribed at an urgent care center. And in, you know, this wisdom, I think we don't, myself included, don't really listen to people who know the most about this, which is the people on the ground experiencing it. She said, what we need is urgent care for the addicted. And she was exactly right, and I think that's what Dr. Burton is doing now at the hospital. So they're not just Narcaning her and turning her out onto the streets with the Xerox of AA meetings, where she's gonna be treated like a leper, you know?
When you're talking about Tess, you spent a great deal of time with her and with her mother. How did you keep enough distance from those characters?
Well, I probably didn't. You know, what I told her, and you can hear it, I think it's maybe even in the podcast, I say at the beginning, I'm not sure if I'm going to be, I hadn't written the book proposal yet. My friend had met her quite by chance, had found her, one of her rescue dogs was running loose, and she returns the dog to the house and finds Tess, a newborn baby, and the grandmother, Patricia, her mom, a hospital nurse, not knowing if she can leave her heroin-addicted daughter home alone with the newborn baby, but she's got to go to work. And so my friend says, Beth is doing this book on heroin, maybe could she come interview? And they said, please, people don't understand how hard it is to access treatment. And so the first time I went, I was just totally transparent. I said, I haven't written the book proposal yet. I know if you'll let me follow you, I'll learn a lot about this. And I did learn a lot about it, just from not only how the daughter of a surgeon who grew up with every advantage that you would think of could become, you know, a heroin addict, homeless and prostituting, but also just how she was denied these life-saving treatments over and over, and was abandoned in many ways by her friends who didn't understand it, and now regret that. Many members of her family, the same. And even her mother wasn't a big fan of that MAT because she had seen her abuse it. And I think it was, there were moments where, so I said, I was just transparent. I won't lie to you, you won't lie to me. And I will let you know as I go how this is going. But there was one moment, maybe halfway through the story, where she reached out to me at night and with a misspelled text. Every word was misspelled. It said, "Please come get me." And she was she was at a drug house. And I didn't see the text right away because my phone was in another room. And I just weighed what to do, and I decided that was, I wasn't going to do that. It was dangerous. I talked to my husband about it. We didn't know what I was going to see, and so I told her mother and her peer recovery coach. And but then I felt bad about it because I thought, well, when I need her, I'll drive her to an NA meeting just to be able to talk to her, but then when she needs me. But, it's really hard to do this kind of reporting without really spending a lot of time with somebody, and you get to know them, and of course you get to care about them. I mean, I've spent so many hours with her mother in particular now that we've done these 2 projects together. We're friends, and what do you do when somebody calls you on the day after Christmas sobbing and says, "I'm so sorry to have to make this call," and her daughter had just been murdered? You just put your notebook down, and you got to be a human being first.
On the day that Tess texted you and asked you to come pick her up, did you all ever talk about that afterwards, why you hadn't, or what?
Mm-mm. We never. When the next time we saw each other, neither one of us brought it up, which I put in the book, and then I wrote a note to my editor in the margin, should I put this in? And she said, absolutely, because it's so painful and it's so true.
So the theme of the festival is power, and you wrote very directly about the role of Purdue Pharma and the Sackler family and the introduction of OxyContin for all sorts of chronic pain in 1996. What role did power play in the opioid crisis, and what should we take away from that?
Yeah, I'm reading this forthcoming book by Deaton and Case, The Deaths of Despair Economists. I'm totally geeking out on it. I love it. And they make this really beautiful, direct statement that says, unlike other countries that didn't abandon their working class and didn't have a government system that totally failed to regulate, and let the corporations basically buy their way into non-regulation of this, America is in this fix. And when you look at almost $1 billion spent on lobbying by the pharmaceutical industry just between 2009 and 2016, you look at the revolving door that happened over and over in this story. Curtis Wright, the head of the FDA, who green-lighted OxyContin, shortly after goes to work for Purdue Pharma. The head legal guy at the DEA shortly goes to work for Big Pharma and ends up writing the law that has a really great sounding name, but basically kneecaps the DEA from suspending suspicious orders. You've read about billions and billions of pills going to one small tiny town in West Virginia that there's no way they were not, misusing, diverting those pills onto the black market. And you just see regulatory failure after regulatory failure. And then just this rent-seeking behavior of sending these pharmaceutical reps to these towns that were already so hurting, right? So maybe people did initially have a workplace injury, but then they get hooked on this new, more powerful drug. And quickly, because there are no jobs there, they realize that if they can get a doctor to write you, and in the beginning you could go to multiple doctors or just cross the state line into West Virginia or North Carolina and get doctors to write you, that they could sell these pills. And that was a way to ameliorate their pain and to pay their other bills, right? So all in the name of greed, in my opinion.
So then what's the lesson for the drug makers, for regulators, for political leaders ahead? How do we not repeat this?
Well, I think we need to be electing people that are really going to take this issue seriously and not just say, we're going to create a national emergency that then releases no new funds. I mean, we know what works because there are some states that are already starting to reduce their overdose deaths slightly, but they're doing all the things I've talked about with the MAT, with the syringe exchange, which is a place where people who are addicted can come in and eventually, when they're ready, be treated like a human being, and then when they're ready, be referred for treatment. But in these rural communities, which have just been decimated, most of these measures aren't happening still. But we know from Rhode Island, Massachusetts, Vermont, that these kinds of things work. There's a police chief in Burlington, I think one of your colleagues has written about, Chief Brandon Del Pozo. He looked at every single overdose death in the year of 2016 in Burlington, and he said, what do they all have in common besides heroin and fentanyl? And it was that all 34 people had come into contact with the police. So they got the police chief, the mayor, the head of the nonprofit hospital, and everybody in a room that had anything to do with it once a month, and they start really going after these cases. And instead of jailing them, which we know from other countries like Portugal, if we can get them into treatment instead, you can save lives. And that's what they did. They turned their overdose death rates down by 50% in 1 year. The police actually drive folks to treatment, even when they catch them with heroin instead of arresting them. Even low-level dealing, they don't arrest for anymore. And so we know these measures work. We're just not doing them at a scale to match the scale of the epidemic. And that's why I say we really need to elect people that are going to take this seriously.
How much is that all going to cost? To do it right, what would it cost?
They say it costs $100 billion to get an addiction treatment system woven within our healthcare system, which we still don't have. And was about what the Ryan White Act that funded on-demand treatment for HIV and AIDS and prevention. But more recently, I'm seeing even much higher estimates for the costs of the opioid crisis. But they're saying $100 billion just to get system in place. And so far, I think the federal government has put about $6 billion to it.
So I think we've all heard something about the legal settlements that are being considered in terms of responsibility over the opioid crisis. What are the pros and cons of this sort of civil settlement?
Yeah, so if I'm thinking about the parents that I've interviewed that were fighting this company since the early days, who lost their children to OxyContin overdose in the early 2000s. I'm on an email message train with them, and they very much want justice to happen. They want the Sacklers to be stripped of their wealth. They prefer that they go to jail. They want them to admit guilt, which seems to be no inclination that any one of these companies is ever going to admit guilt. And they don't want them to settle because they want the truth to come out. As one of them, Ed Bish, said, they were allowed to continue. This crisis got so much worse in those early settlements that happened in like Kentucky and West Virginia in the early years, largely because of all that data, all those depositions were sealed. And so the truth couldn't come out. And these families really want, more than anything, they want treatment to be made accessible and on demand in the name of their loved ones, like a legacy kind of thing. And you know, there's a lot of comparisons to the tobacco settlement, which happened, I think, in the mid-90s. That was about $246 billion. And I don't think the opioid settlement is thought to gonna be to that level because they don't have the money that tobacco had. And so, which is why we really need a holistic approach, I think.
So should the Sacklers go to jail?
The parents believe they should. The parents I talked to believe they should. They believe they've experienced unfathomable pain, and the Sacklers should as well. You know, New York Attorney General has evidence that they've been socking their money away on offshore accounts. And, you know, they're still going to come out of this being billionaires. And those families believe they should feel the pain that they have felt.
Okay. What was the hardest part of putting this book together?
Being a reporter working in my kid's ex-bedroom, kind of all on my own, and feeling like I'm taking on these giant billionaire corporate entities was a little intimidating at times. I'm not going to lie to you. The hardest thing was just witnessing over and over every story I touched, every story, just so much pain that these families are suffering with, and seeing them struggle. Tessa's mom says it's like watching a loved one slowly drown. And how to put that story into context in a way that'll make, another editor friend of mine said, it's not your job to fix it as if I could, but it's your job to make people care. And how do you present that in a way that's gonna help relieve the stigma that still keeps politically, keep the stigma. It affects every aspect of this, whether it's we're not taking it seriously, our government's not taking it seriously, it's the last thing they talk about in the debates, you know, and the stigma about the medications and our hospital systems taking it seriously. It was writing in a way that would make people care about it, and I did that by just getting to know those people that were suffering. I mean, there were some people I interviewed who died before I got home and was able to type up my interview notes. And that had never, you know, that's not something that happened. I mean, I hadn't had that experience before.
Are there any heroes to this story?
Absolutely, there's so many heroes. I think Dr. Van Zee is such a hero. You know, he was the first to say this drug is killing people, I don't think it's safe. You know, he went to Washington, to FDA headquarters, he tried for years. He wrote him a letter in 2000 saying, look, my fear is that these distressed rural communities are sentinel areas the way New York and San Francisco were in the early years of HIV. And I'm like, gosh, reading that letter now, so prescient. I mean, there are public health heroes every day that are sticking their necks out on a limb, battling communities that don't want methadone clinics in their backyard because, you know, what happens if somebody gets too big a dose and then they run into a school bus? And these heroes are going out and they're tackling these angry crowds in some places. I tell the story near the end of the book, a group of collaborators, public health, criminal justice people, they all came together about 6 years ago in Johnson City, Tennessee, and they realized they needed to open a nonprofit health clinic, and nobody in that town of 3,000 wanted it. So they just had to be willing to get their butts kicked over and over in meetings. And finally, in one of the last meetings, somebody shouts, you know, put it in your backyard. How many chances are we supposed to give these people? And the guy who was leading the meeting is an addiction doctor himself. He had been addicted to OxyContin, had been in recovery, I think 14 years at the time. But at the height of his addiction, he broke his own ankle so he'd have surgery, so he could get more pills. He broke his own ankle, and he sees a scar every day when he puts his socks on it. It's like a reminder. Plus, he has to check in. He has to go be randomly drug tested, still 4 times a year. And so he's trying to get this crowd like, no, these people, they're savable if we can get them help. And so somebody says, how many chances are we supposed to give these people? You Narcanon the same people over and over. And he's from rural Tennessee himself, and he realizes he's gone to church and played ball with half the people in the room. And he thinks of the disciple asking Jesus, how many chances should a sinner be forgiven? Should he be forgiven 70 times or 7 times? So Dr. Steve says to the angry woman, 70 times 7. That's how many chances these people should be given, because addiction is a chronic relapsing disease. I was reporting a similar kind of community in rural North Carolina a couple months ago. Same thing happened. A bunch of do-gooders in the room. They realized they had a really high opioid overdose rate. And the problem in rural communities is that they can't get rides to treatment, and you have to go a lot. If in methadone, you have to go every day. Buprenorphine, once a week to begin with. And they didn't have ways to get there, so they had these really well-meaning church people say, here, use our van, we'll take people to treatment. And the meeting gets hijacked by somebody saying the same thing that the woman in the other meeting said. She said, I think when they relapse, we should let them die and take their organs. So that stigma is still out there. I mean, they eventually turned the meeting. This was the head of the local Kiwanis Club. And I know it just feels like you're beating your head against it, but we've got to change hearts and minds on this. And I think the stigma still is the #1 problem, because all the access issues kind of flow from that.
You mentioned much earlier that Tess had at one point abused the MAT. Mm-hmm. What does that mean?
Well, some people have figured out how to inject it, how to get the naloxone or the I forget the word for the naloxone. Shout it out if anybody knows. Yeah. But there's a component in that, in the buprenorphine, that they've figured out how to do an end run around it. Tess herself told me she doubled up when she was stressed, even though it has a ceiling effect. And so
I see.
And then eventually her mother found like little glassine bags to indicate that she was.
So wouldn't that play into the argument that people make about you don't want to give an addicted person more drugs?
It does, but the important thing to remember is that the people largely who are fighting this and saying this aren't seeing the people for whom it's working. Mm-hmm. And oftentimes it does take 3, 4, 5 times, but eventually, whenever she was on it and using it correctly, she was doing better. And I do think she would have gotten better. But it's an observation bias, and the people who are on it and using it responsibly and getting their children back and their families and recovering, they don't want to necessarily stand up and shout it from the rafters because of the stigma and the way they're treated. So that's why it's so important to tell these stories.
So let me ask you one more question or two before we turn to questions from the audience. So you all should be thinking about what you want to ask. But you talked for a minute about your earlier book, Factory Man, which addressed the effects of globalization on American workers. Is there some intersection between these stories?
Oh, totally. So Factory Man mostly takes place in a county called Henry County, Virginia, which was kind of the factory floor for Virginia. It was a lot of textile mills and furniture factories. And when you actually went back and tallied up all the jobs, it wasn't just the factories, but it was the place where the factory workers spent their money. And like mom and pop diners and furniture stores and things of that nature. They had lost half of their jobs. And when I set out to tell that story through the lens of a furniture maker who actually sued China in a court of international trade to keep his factory elsewhere going as sort of the hero outlier, I was very much motivated by telling what was going on in most of the places where that didn't happen. They didn't have somebody standing up for the little guy. And what I was seeing at the end of that book, which I finished up in 2013, is this drug crime escalating, jails filling up, abandoned plants burning down by accident by people who were ripping out copper wiring to sell on the black market. And I sort of just assumed they were jobless and desperate to feed their families, but I only later learned that no, it was actually because they were dope sick. They had the fear of dope sickness, that they were doing this to sell the copper wiring on the black market. And then only in 2016 did the CDC show the numbers for prescribing, opioid prescribing. Martinsville, Virginia was -- 1 in the country in Henry County. So when you look at the data, it's very clear in those places that have higher numbers of, lower numbers of workforce participation, they also have higher opioid prescribing, and then wherever you have higher opioid prescribing, you also have higher overdose deaths. So it's like a map of where the jobs went away, where at first, and it continues to be true. And those are also the places that tend to have these cultural barriers, where they don't want to have a syringe exchange because they think that's enabling users.
Is there anything that people should be prescribed opioids for?
Oh yeah, absolutely. Cancer, end of life, post-surgery. But when I was finishing the book, they were still saying that surgeons were giving twice as many pills post-surgery as people actually need. And I don't know if that data is still up to date, but I have a surgeon friend. I was at a party one night. He'd had a couple drinks. And I said, Chuck, why do you all give out so many post-surgery opioids? And I said, he had had a couple drinks. And he said, because we don't want to be called at home on the weekend if you need more.
It's a really bad answer.
It was a really bad answer. I felt like it was a really honest answer. And, I floated this notion at a doctor meeting I was invited to speak at right after Tessa died. It was before the book came out, and I was very emotional. I mean, I wasn't crying, but my voice was shaking. And I said, and it was a medical school in my community affiliated with Corellian, the nonprofit. And I said, I feel like any of you all, whoever took a free item from a pharmaceutical company, even just Post-it notes and pens, OxyContin, coffee mug, should feel morally compelled to become waivered to prescribe buprenorphine. And they didn't want, and it was crickets, actually. Nobody said anything, like you could have heard a pin drop. But 6 months later, this is the nonprofit hospital that took it on. But, a lot of physicians don't think they want, quote, addicts in their waiting room, and I don't like to use that word. It's harsh and judgy. But sorry, you helped get us into this. You need to try to help get us out, and they're already there in your waiting room. They just are.
All right. If you have questions for Beth, there are microphones, folks with microphones ready to start taking them. So great, we have lots. And just one suggestion, let's make sure so we can get to as many questions as possible. Try to get to your question.
Hi, hope this is a quick question. When the treatment doesn't work, is there a pattern that can indicate that it's not working, or a specific symptom that it's not working?
When you say treatment, do you mean specifically the medication-assisted treatment?
Yes.
Okay.
Yes.
And when it's not working, so as I said, oftentimes it takes multiple attempts, right? I have a piece coming out in the Atlantic in a couple months about a young woman who works for a nonprofit hospital system in Indiana, and she was all about the MAT because she was all about the research, and she was realizing that they started offering MAT through her hospital, but nobody was coming back to do it because it's hard, right? And so then she partnered with the court system in town. This is a town so small, really terrible opioid problem. Didn't even have a drug court. But she got the judges to let her do a 9-hour intensive IOP, outpatient program, inside the courthouse. So those folks have, they work on their trauma, they have a licensed clinical social worker, they have 4 drug tests a week. And one of the participants said, we can't get away with shit. And And these are people who've been in and out of jail their whole lives, and nothing has ever worked for them. But that stick waiting that you're going to have to go back to jail, so that's part of it. That does help. But also, they help them get jobs. The program's from 5 to 8, 3 nights a week, so they work during the day. They get them on MAT. They get them signed up for Healthy Indiana, which is their Medicaid. And they throw all sorts of resources. They're working on now getting a sober living house. So I think when you have the counseling paired with it and you have help with the social supports, it tends to be easier to do. But it still is going to take people multiple chances, most likely. Because we don't have, in our country, we don't have those kind of social supports. Thank you.
Back here, oh, I'm sorry, this is very loud, on your right.
Hi.
Hi.
In parallel, it seems we also have this growing crisis of treatment centers not really treating patients and just being there for the insurance money. I don't know if you saw that in your reporting or if you have any comments about that.
Yeah, I saw that over and over again in my reporting. I saw that happen with Tess. You know, the place she went out to in Las Vegas, I think it was $20,000 or $28,000 for a month. And of course, they didn't allow MAT at the time. I think they are now. Only 3% of all rehabs in the country offer all 3 kinds of MAT. And that's back to your question. People experience addiction differently, and people recover differently. So most experts believe they should have access to methadone, buprenorphine, or naltrexone, which is the third kind. It's the injectable kind. But there's this rehab industry is really taking advantage of people who are vulnerable and desperate to do anything. And sometimes they work. There's a family in my book, a surgeon's wife and surgeon spent $300,000 on their 2 heroin-addicted sons, who are doing pretty good now. But that's another industry we should really be looking at and regulating and standardizing. There's a beautiful series right now, it's ongoing, by Vox, by a reporter named Germán Lopez, who's really taking an in-depth look at that.
I have a relative who is the disorder, prison, theft from family. You know all the details. I've read your book 3 times because it has taught me the humanness of my relative, plus the book Dreamland by Sam Quinones. I'm wondering if you and Sam have had much contact or if ever been on the stage together.
No, I haven't had the pleasure. We've exchanged some emails, and he was kind enough to give me advice on how to do an interview in prison, which I had never done before. I had helped him out with something unrelated a few years earlier, and he basically warned me, you're not allowed to record when you go to a prison, and you probably won't get an interview. But I persisted. My publisher had to send a letter, and when they said they gave me 2 hours, questions, 3 pens, and then they let me stay for 6 hours without recording, so my hand was like this at the end. And I didn't go to the bathroom. I was dying to go to the bathroom. But, you just let somebody, if they'll let you keep talking, you keep talking. But so I was glad that he sort of told me how to do that. I had never been in a prison before.
And on your right again.
Oh, thank you. Hi, I wonder if you'd comment a bit on how this intersects with underdiagnosed and untreated mental health services in the United States. We've had a lot of experience with addiction in our family and among my kids' friends, and there's always a mental health element, and I don't hear you talking about that.
Yeah, no, I think you're exactly right. I think the data about the adverse childhood experiences underscores that. I mean, this program I was just talking about in Indiana, their combined, their average ACE scores, and I think the highest is 10, but they're all right there near at the top. And these are folks that are largely self-medicating and haven't had access to mental health services. And we know that all kinds of people can be vulnerable to opioid addiction, but people with those comorbidities, anxiety disorders, untreated anxiety disorders. We were talking earlier about the thread in the book of people who are overdiagnosed with ADHD, and how I just happened to notice as I was interviewing all these moms that many other kids had started out taking Adderall and Ritalin, and then when they got to high school, pills became part of the culture, and then they started trading them for opioid pills and harder things. And so there's a connection between that too. But I agree that lack of parity for mental health treatment, which I think, Affordable Care Act addresses somewhat. We still have 14 states that haven't passed the Medicaid expansion though. So what we have here is what I call the uneven states of America, where if you're in Massachusetts, you're going to have access to what science says is the best treatment. But if you're in North Carolina, chances are you might not. Yeah.
Hi, enjoyed your talk. I admit I haven't read the book. I'm a physician. I'm sure there are many other physicians here. A few weeks ago, I happened to read an article that talked about opioid use disorder in particular and medication-assisted treatment for physicians. And one of the sad takeaways, though, was this distinction that in certain states it would be easier to remain a physician as long as you were complying. But in other states, I think what it boiled down to was the concern that if you have a physician, and you could extrapolate that to a lot of professions, the teachers, the police, the airline pilots, anybody with the issue, and then maybe using medication as some substitute, maybe you don't want them doing the job that they're supposed to do, because all of a sudden, if there's a bad outcome, people in the law profession, we are famous for that in this country, and this is where, getting into the whole issue of, so we have the states with different cultures, we have a certain fear of litigation. So I know your focus was kind of in these sort of, we'll say, the abandoned rural areas where they've been disenfranchised because of globalized economy, but one of the reasons that, people that sit here in an audience here in Chicago are going to be, as a rule, coming from a higher socioeconomic and educational levels, so some of these professions will be more likely to be at risk there. Just so basically the comment, could you, regarding the medication-assisted treatment and how the use or acceptance of it varies even among a higher level of educated professions.
Absolutely. That's something Dr. Steve talks about. He says airline pilots and doctors get the absolute best treatment because they can afford it and because their industry has, spent a lot of money getting them to the level that they're at. And, so he gets to go away for 9 months. He gets what the science says is the best, but we're not doing that with regard to many professionals.
We have time for a few more. Here, right up here in front.
Hi. You hear about the overprescribing, which is definitely an issue, but you also hear about people with chronic pain conditions who are often treated as though they're addicts or have their problems dismissed when they go to doctors and have these long diagnoses processes. Do you feel like both of these things are reflections of the same kind of stigma? Or if not, how do you deal with limiting overprescribing while also having autoimmune conditions and chronic pain conditions treated seriously?
Right. So the pendulum is swung back the other way, and I hear that quite a bit when I travel and talk about example after example, people who are using their pain meds responsibly being suddenly cut off because of doctors' fears with all this negative press. And of course, that's terrible as well. We don't do anything with nuance very well in this country. There's a beautiful book that just came out in February by a bioethicist at St. Johns Hopkins named Travis Reeder, and it's called In Pain. And he's a bioethicist who himself got in a terrible wreck and found himself dependent on opioids, and nobody knew how to They just didn't want to touch him after a while. They didn't know how to treat him. He was shuffled from one pain doctor to an addiction specialist to, I think, 5 different doctors. And so he really parses the issue out well in that book, but he basically comes away with doctors aren't trained in how to deal with pain. And we need, and that if you are going to taper somebody, you shouldn't force taper them, and you should do it very, very slowly. I think you would enjoy that book.
Time for just one more.
Hi.
Hi.
So one of the promises that keeps appearing on the horizon during the opioid epidemic is that the United States will finally follow in the footsteps of many other places that have implemented safe injection facilities within major cities. And we've seen this fail in Seattle and San Francisco, and now maybe being in the works in Philadelphia. And if there's a real stigma attached to something like medication-assisted treatment, which is ostensibly less public, and then looking at something like safe injection facilities, which are arguably far more public and unpalatable to not in my backyard sorts of parties, do you think there's any hope anytime in the near future of a city implementing safe injection facility?
Well, I surely hope so. I think that's any place, whether it's a syringe exchange or a safe injection facility, any place that brings people into contact with folks who are going to help them. And, you know, I interviewed a guy who had been a heroin user in New York City for 10 years, and he went into a syringe exchange, and they said, "What do you need? How can we help you?" And he said, in the throes of his addiction, he said, "I'm hungry. Do you have a sandwich?" And he said that sandwich ended up changing his life because they treated him like a human being. They eventually helped connect him to services. And he now runs an addiction treatment center in Johnstown, New York, in a former furniture factory, ironically. And I just think the more people start to understand that, we've got great models for safe injection facilities in Canada, in Portugal, and other places. If we can start to, we can broaden this notion of bringing people in and treating them as the least of our brethren, that's the only way we're going to chip away at this. Thank you all for coming out.
Yeah, thank you so much for being here. And thanks to Beth Macy and
Thank
your
you,
wonderful
Monica.
work. I really appreciate it.